Oxygenation, Chapter 41. Disturbances in oxygenation result from ineffective gas exchange in the lungs or an ineffective pump in the heart. Cardiac and respiratory systems both work together to supply the body with oxygen that is needed for carrying out the respiratory and metabolic processes that are needed to sustain life. Blood is oxygenated through the mechanisms of ventilation, perfusion, and transport of respiratory gases. Respiration can be defined as the exchange of oxygenation and carbon dioxide during cellular metabolism. The airways of the lungs transfer oxygen from the atmosphere to the alveoli, where the oxygen is exchanged for carbon dioxide. Through the alveolar capillary membrane, the oxygen transfers to the blood, and the carbon dioxide transfers from the blood to the alveoli. Ventilation is the process of moving gases into and out of the lungs, with air flowing into the lungs during inhalation, which is at inspiration, and out of the lungs during exhalation or expiration. Perfusion is the ability of the cardiovascular system to pump oxygenated blood to the tissues and return deoxygenated blood to the lungs. Diffusion is moving the respiratory gases from one area to another by the concentration of gradients. The work of breathing, in inspiration, it is an active process. It is stimulated by chemical receptors in the aorta. Expiration is a passive process that depends on elastic recoil of the lungs, requiring little or no muscle work. Surfactant is a chemical that is produced in the lungs to maintain the surface tension of the alveoli and to keep them from collapsing. For lung volumes, the tidal volume is the amount of air exhaled following a normal inspiration. The residual volume is the amount of air that is left in the alveoli after a full expiration. Pulmonary circulation is the movement of blood to and from the alveoli capillary membrane for gas exchange. Pulmonary circulation begins at the pulmonary artery, where it receives poorly oxygenated mixed venous blood from the right ventricle. The blood flow depends on the pumping ability of the right ventricle. The flow continues from the pulmonary artery through the pulmonary arterioles to the pulmonary capillaries. Here, the blood contacts with the alveolar capillary membrane, and the exchange of respiratory gases occurs. The oxygen-rich blood then circulates through the pulmonary venules and the pulmonary veins. Then it returns to the left atrium. Diffusion is the process for the exchange of respiratory gases in the alveoli of the lungs and the capillaries of the body tissues. The diffusion of respiratory gases does occur at the alveolar capillary membrane. The thickness of the membrane will affect the rate of diffusion. An increased thickness of the membrane will impede diffusion because the gases will take longer to transfer across the membrane. The oxygen transport system consists both of the lungs and the cardiovascular system. The delivery depends on the amount of oxygen that enters the lungs, the blood flow to the lungs and the tissues, the rate of diffusion, and the oxygen carrying capacity. There are three things that influence the capacity of blood to carry oxygen. The first is the amount of dissolved oxygen in the plasma. The second is the amount of the hemoglobin. And the third is the ability of the hemoglobin to bind with oxygen. Carbon dioxide, which is a product of cellular metabolism, diffuses into red blood cells, and it is rapidly hydrated into carbonic acid. Carbonic acid dissociates into hydrogen and bicarbonate. The hemoglobin will buffer the hydrogen ion, and the bicarbonate diffuses into the plasma. A reduced hemoglobin combines with carbon dioxide, and the venous blood transports the majority of carbon dioxide back to the lungs to be exhaled. The regulation of ventilation required to ensure sufficient oxygen intake and carbon dioxide elimination is necessary to meet the demands of the body. Cardiopulmonary physiology. The delivery of deoxygenated blood, or blood that is high in carbon dioxide and low in oxygen, goes to the right side of the heart and to the lungs where it is oxygenated. Oxygenated blood, which is blood that is high in oxygen and therefore low in carbon dioxide, will travel from the lungs to the left side of the heart and the tissues. The cardiac system delivers oxygen, nutrients, and substances to tissues, as well as facilitates the removal of cellular metabolism waste products by blood flow through other body systems, like the respiratory, the digestive, and the renal system. The right ventricle pumps deoxygenated blood through pulmonary circulation. The left ventricle pumps oxygenated blood through the systemic circulation. The pumping action of the heart is essential to oxygen delivery. There are 4 cardiac chambers, 2 atria and 2 ventricles. The ventricles fill with blood during diastole and empty during systole. The volume of blood that is ejected from the ventricles during systole is stroke volume. The blood flow through the heart is unidirectional, and it is controlled by heart valves. The coronary circulation is a branch of systemic circulation that supplies the myocardium, or the heart muscle, with oxygen and nutrients and removes the waste materials. The arteries of systemic circulation deliver nutrients and oxygen to tissues, and the veins remove the waste materials from the tissues. The amount of blood ejected from the left ventricle each minute is cardiac output. The normal cardiac output is 4 to 8 liters per minute in a healthy adult. The conduction system begins with the SA node, or the pacemaker of the heart. The SA node is in the right atrium. Impulses are initiated at the SA node at a rate of 60 to 100 beats per minute in an adult. The electrical impulses are transmitted through the atria to the AV node. The AV node mediates impulses between the atria and the ventricles. It assists in atrial emptying by delaying the impulse before transmitting through the bundle of His and the ventricular Purkinje network. Normal sinus rhythm is necessary to ensure optimal perfusion of the body tissues. While reading this case study, what barriers to healthcare can you identify? How do you think John's experiences will affect his interaction with his patient. What should John do next in this situation? How could John engage in the subject of smoking cessation with his patient? What organizations would have information that may help the patient understand the seriousness of continued smoking? Consider the American Cancer Society and the American Lung Association. Physiological factors are any condition that affects the cardiopulmonary functioning directly. Then this affects the ability of the body to meet the oxygen demands. Hemoglobin carries the majority of oxygen to tissues. Anemia and inhalation of toxic substances decreases the oxygen carrying capacity of blood by reducing the amount of available hemoglobin to transport the oxygen. Hypovolemia, there are specific conditions like shock and severe dehydration that can cause extracellular fluid loss and reduced circulating blood volume. The decreased circulating blood volume results in hypoxia to the body tissues. With the decline of concentration of inspired oxygen, the oxygen carrying capacity of the blood decreases. Decreases in fraction of inspired oxygen concentration, or FiO2, is caused by upper or lower airway obstruction, decreased environmental oxygen, or hypoventilation. Increased metabolic activity increases oxygen demand. The level of oxygenation declines when the body systems are unable to meet the oxygen demand. As the fetus grows during pregnancy, the enlarging uterus pushes the abdominal contents upward against the diaphragm. Patients that are morbidly obese have reduced lung volumes from the heavier lower thorax and abdomen, particularly when in the recumbent and supine positions. Musculoskeletal impairments in the thoracic region reduce oxygenation. Flail chest is a condition in which there are multiple rib fractures that cause chest wall instability. This instability allows the lung under the injured area to contract on inspiration and bulge on expiration, resulting in hypoxia. Patients with thoracic or upper abdominal surgical incisions use shallow respirations to avoid pain. This also decreases the chest wall movement. Neuromuscular diseases affect tissue oxygenation by decreasing the patient's ability to expand and contract the chest wall. Diseases or trauma to the medulla oblongata and or the spinal cord result in impaired ventilation. When the medulla oblongata is affected, the neuroregulation of ventilation is impaired and abnormal breathing patterns will develop. Cervical trauma at C3 to C5 will routinely result in paralysis of the phrenic nerve. This causes the inability to breathe appropriately. Oxygenation decreases as a direct result of chronic lung disease. As alveolar ventilation decreases, the body retains carbon dioxide. As more alveoli collapse, the less of the lung is ventilated and hypoventilation will occur. Severe anxiety, infection, drugs, or an acid-base imbalance will induce hyperventilation. Acute anxiety will also lead to hyperventilation and the exhalation of excessive amounts of carbon dioxide. Hypoxia results from a deficiency in the oxygen delivery or oxygen use at the cellular level. This is a life-threatening condition. If it is untreated, it has the potential to produce fatal cardiac dysrhythmias. Cancer is the greatest killer of American population. The American Cancer Society notes that lung cancer, both small cell and non-small cell, is the second common cancer in both genders within the United States. In men, prostate cancer is common, while in women, breast cancer is common. 13% of all new cancers are lung cancers. Electrical impulses that do not originate from the SA node or the pacemaker of the heart can cause conduction disturbances. Rhythm disturbances are also known as dysrhythmias. This means a deviation from normal sinus heart rhythm. Dysrhythmias can occur as a primary conduction disturbance in response to ischemia, valvular abnormality, anxiety, drug toxicity, caffeine, alcohol, or tobacco use, or as a complication of acid-base imbalance or electrolyte imbalance. Left-sided heart failure is an abnormal condition causing decreased functioning of the left ventricle. Left ventricular failure is significant because this is the amount of blood that is ejected from the left ventricle, and it greatly reduces, causing a decreased cardiac output. Signs and symptoms of left-sided heart failure will include fatigue, breathlessness, dizziness, confusion due to hypoxia. The blood pools in the pulmonary circulation. This causes pulmonary congestion. There will be findings of crackles in the bases of the lungs on auscultation, hypoxia, shortness of breath, cough, paroxysmal nocturnal dyspnea. In right-sided heart failure, this is due to impaired functioning of the right ventricle. This is commonly due to pulmonary disease or long-term left-sided heart failure. The primary pathological factor in right-sided heart failure is elevated pulmonary vascular resistance. When pulmonary vascular resistance increases, the right ventricle works harder. The oxygen demand of the heart increases. The failure continues, and the amount of blood ejected from the right ventricle continues to decline. The blood then begins to back up in the systemic circulation. Signs and symptoms of right-sided heart failure include weight gain, distended neck veins, hepatomegaly, splenomegaly, and dependent peripheral edema. Valvular heart disease is an either acquired or a congenital disorder of a cardiac valve that causes stenosis or hardening, or it can cause regurgitation or an impaired closure of the valves. Myocardial ischemia results when the supply of blood to the myocardium from the coronary artery is insufficient to meet the myocardial or the heart oxygen demands. Angina pectoris, this is a transient imbalance between the myocardial oxygen supply and demand. This condition results in chest pain that is aching, sharp, tingling, or burning, and it may feel like pressure on the chest. A myocardial infarction or acute coronary syndrome results from sudden decreases in coronary blood flow or an increase in the myocardial oxygen demand without adequate coronary perfusion. A heart attack or an infarction occurs because ischemia is not reversed. The cellular death will occur after 20 minutes of myocardial or heart ischemia. The developmental stage and normal aging process affect tissue oxygenation. Lifestyle modifications are often difficult for patients because they have to change an enjoyable habit like cigarette smoking or eating certain foods. Good nutrition affects the cardiopulmonary function by supporting normal metabolic functions. A poor diet can lead to risk factors that affect the heart and the lungs. Fluid intake is vital for cellular health. Exercise will increase the metabolic activity and the oxygen demand of the body. The rate and depth of the respirations will increase, enabling the individual to inhale more oxygen and exhale excess carbon dioxide. Cigarette smoking and secondhand smoke are associated with a number of diseases, heart disease, COPD, and lung cancer. Stress is a perceived threat to the system that results in sympathetic stimulation. Continuous stress will adversely affect the patient's health and well-being. Our environment influences oxygenation. The prevalence of COPD is higher in rural areas versus those that live in urban areas or cities. As nurses, we need to apply critical thinking measures so we can assist our patients to live in their best form of health and wellness for them. These are agencies that have specific standards that we as nurses use every day. Clinical judgments require the nurse to anticipate information, analyze data, and make decisions regarding the patient's care. During assessment, all elements should be considered that build toward making an appropriate nursing diagnosis. To understand how alterations in oxygenation affects a patient, the selection of interventions, the nurse needs to integrate knowledge from nursing as well as other disciplines and the information that is gathered from the patient. Critical thinking attitudes will ensure that the nurse approaches the patient care in both a methodical and a logical way. Cardiopulmonary problem questions that the nurse will ask upon assessment. The first set describes the problem that the patient is having with their heart. Does the problem, chest pain, rapid heart rate, occur at a specific time of the day, during or after exercise, or all the time? Do you notice abnormal beats? If you have chest pain, what makes it better or makes it worse? The nurse will also ask questions associated with breathing. Describe the breathing problems you're having. Has your breathing pattern changed? Do you have a cough? Is the cough increasing? Is it better or worse at a certain time of the day? Describe your cough. Is it dry or moist? Do you have sputum when coughing? Is the sputum different in color, volume, or thickness? On a scale of 0 to 10, with 10 being the most severe, rate your shortness of breath. What helps alleviate the shortness of breath? The nurse will also ask questions related to chest pain. If you're having chest pain, what causes the pain and how long does it last? Is it a different type of pain? Can you show me where the pain is located? Does the chest pain occur with coughing? On a scale of 0 to 10, with 0 being no pain and 10 being the most severe pain, rate your chest pain at its worst. Is the pain different today? The nurse will also ask questions to regard thinking about predisposing factors. Have you been exposed to a cold or the flu or any other respiratory illness? Tell me about the medications you are currently taking. Do you take over-the-counter medications or supplements? And if you do, what are they? Do you smoke? Have you been exposed to secondhand smoke? Have you been doing any unusual exercises? The nurse will ask questions regarding the effects of the symptoms. Describe for me your typical daily diet. Tell me how your symptoms affect your activities of daily living, your appetite, your sleeping, and your exercise routine. The physical examination includes the assessment of the cardiopulmonary system. The nurse needs to consider when assessing an older adult the changes that occur normally with aging. Changes affect activity tolerance, level of fatigue, or cause changes in vital signs, and they're not always associated with cardiopulmonary disease. Using inspection techniques, the nurse will perform a head-to-toe observation of the patient for skin and mucous membrane color, general appearance, level of consciousness, adequacy of systemic circulation, breathing patterns, and chest wall movement. Palpation of the chest provides assessment data. It documents the type, the amount of thoracic excursion, elicits areas of tenderness, helps to identify tactile fremitus, thrills, heaves, cardiac point of maximum impulse. The palpation of extremities provides peripheral circulation, skin temperature, color, capillary refill, the presence and quality of peripheral pulses. Percussion detects the presence of abnormal fluid or air in the lungs. It can also determine diaphragmatic excursion. Auscultation helps identify normal and abnormal heart and lung sounds. The auscultation of the cardiovascular system includes normal S1 and S2 sounds, and the presence of any abnormal S3 or S4 sounds, which are gallops, murmurs, or rubs. After taking the patient's vital signs, what other assessment steps could John take? These are the assessment steps that John took. What nursing diagnosis should John use? A patient complains of chest pain. When assessing the pain, you decide that its origin is cardiac rather than respiratory or gastrointestinal. When it does not occur with respiratory variations, is peripheral and may radiate to the scapular region, is aggravated by inspiratory movements, is non-radiating, and occurs during inspiration? The answer is A, does not occur with respiratory variations. The nursing diagnostic process for impaired gas exchange related to decreased lung expansion. The assessment activities would be to ask the patient about their mood, attentiveness, memory, and activity level. Think about confusion, decreased activity, fatigue, irritability, restlessness, and sleepiness. Observe the patient's respirations for rate, rhythm, and depth. Think about dyspnea, nasal flaring, tachypnea, use of accessory muscles. Inspect the skin and the mucous membranes. Think diaphoresis, pallor, and cyanosis. Auscultate the chest. Think about respiratory excursion that is decreased, abnormal lung sounds, or distant lung sounds. When planning for a patient that has respiratory and cardiopulmonary issues, the nurse needs to select interventions that will promote the oxygenation necessary for the patient's body system. Remember, when planning, we need to involve both the patient and their family members. What expected outcomes would accompany these goals? What interventions may be used to help the patient achieve the outcomes? Maintaining the patient's optimal level of health will reduce the number and/or the severity of respiratory symptoms. The prevention of respiratory infections is the utmost importance in maintaining optimal health for the patient. You need to pay attention to box 41.6 on the next slide. There are 4 diagnoses that are determined with the health assessment and the medical diagnoses. Impaired gas exchange, activity intolerance, acute pain, and impaired airway clearance. These are the 4 nursing diagnoses. Dyspnea is difficult to treat. Want to maintain airway patency when the trachea, bronchi, and large airways are free from obstructions. Airway maintenance requires adequate hydration to prevent thick and tenacious secretions. The ability of the patient to mobilize pulmonary secretions makes the difference between a short-term illness and a long-term recovery that involves complications. The maintenance of adequate systemic hydration keeps the mucillary clearance normal. Humidification is the process of adding water to gas to always keep the airways moist. This is necessary for patients that receive oxygen therapy at high flow rates greater than 4 liters per minute. Nebulization adds moisture to inspired air by mixing particles of varying sizes with the air. Aerosolization suspends the maximum number of water droplets or particles of the desired size in the inspired air. Coughing is an effective technique for maintaining a patent airway. Postural drainage is a component of pulmonary hygiene. It consists of draining, positioning, and turning. It is sometimes accompanied by chest percussion and vibration. This will aid in improving secretion clearance and oxygenation. Positioning involves draining the affected lung segments. Note Table 41.6 in your text. Positive expiratory pressure is an airway clearance technique that can be used with and without oscillation. Its use is typically reserved for patients that have cystic fibrosis or other lung diseases where sputum is retained. A cappella and flutter devices are commonly used PEEP devices. The device allows air to be inhaled easily but forces the patient to exhale against resistance. This action helps the air get behind the mucus, which then makes it easier to expirate the mucus. Immobility is a major factor in developing atelectasis, ventilator-associated pneumonia, and functional limitations that include muscle weakness and fatigue. The 45-degree semi-Fowler's position is most effective to produce lung expansion and reduce pressure from the abdomen on the diaphragm. Incentive spirometry encourages voluntary deep breathing by providing visual feedback to patients about their inspiratory volume. There are rationales for the interventions. The major complication of reduced mobility is the retention of pulmonary secretions. This predisposes the patient to atelectasis and pneumonia. Ambulation, sitting upright, and frequent position changes are consistent with normal activities and promote normal lung function and mucillary clearance. The fluid intake of 2,800 milliliters in 24 hours will help to liquefy secretions for easier removal. Caffeinated and alcoholic beverages promote diuresis and dehydration. Water is an effective expectorant. It is easily available and cost-effective. Suctioning is necessary and often required when patients are unable to clear respiratory secretions from the airways by coughing or other less invasive procedures. Suctioning techniques include oropharyngeal and nasopharyngeal suctioning, orotracheal and nasotracheal suctioning, and suctioning in artificial airway. An artificial airway is used for a patient with a decreased level of consciousness or airway obstruction, or one that is in need of prolonged ventilation support, and it aids in the removal of tracheobronchial secretions while maintaining a patent airway. The presence of an artificial airway places the patient at high risk for infection and airway injury. Invasive mechanical ventilation, also known as positive pressure ventilation, is a life-saving technique used with artificial airways. The physiological indications for invasive mechanical ventilation include supporting the cardiopulmonary gas exchange, increasing the lung volume, and reducing the work of breathing. Ventilator-associated pneumonia is a significant potential complication because the artificial airway tube bypasses many of the airways and the lungs' normal defensive mechanisms. Ventilator-associated pneumonia is a healthcare-acquired infection that develops 48 hours or more after an endotracheal intubation and mechanical ventilation. A patient with a tracheostomy has thick and tenacious secretions. To maintain the airway, the most appropriate action for the nurse includes tracheal suctioning, oropharyngeal suctioning, nasotracheal suctioning, orotracheal suctioning. The answer is A, tracheal suctioning. Notice how John has empowered the patient in resolving his health crisis. So which outcomes have been met and how might they be documented? Think good daily fluid intake, secretions are thin, white, and watery, outcome met. The patient ambulates for about 5 minutes, outcome not completely met. Secretions are thin, the lung is clear, and there's no evidence of infection noted. The outcome is met. The promotion of lung expansion, mobilization of secretions, and maintenance of a patent airway assists patients in meeting their oxygenation needs. The goal of oxygen therapy is to prevent or relieve hypoxemia by delivering the lowest amount of oxygen possible and achieving adequate tissue oxygenation. Oxygen is a highly combustible gas. It is a therapeutic gas that must be prescribed and adjusted by a healthcare provider's orders. If a patient's hypoxia is severe and prolonged, cardiac arrest will result. A cardiac arrest is a sudden cessation of cardiac output and circulation. When this occurs, oxygen is not delivered to tissues, and carbon dioxide is not transported from tissues. The tissue metabolism becomes anaerobic, and metabolic and respiratory acidosis occurs. Permanent damage to the heart, brain, and tissues will occur within 4 to 6 minutes. Respiratory muscle training improves muscle strength and endurance. This results in improved activity tolerance. Breathing exercises include techniques to both improve ventilation and oxygenation. Pursed lip breathing involves deep inspiration and prolonged expiration through pursed lips. This prevents alveolar collapse. Diaphragmatic breathing is useful for patients that have cardiopulmonary disease and dyspnea secondary to heart failure. The indications for home oxygen therapy include an arterial partial pressure of 55 millimeters of mercury or an arterial oxygenation saturation of 88% or less on room air at rest, on exertion, or with exercise. When evaluating a post-thoracotomy patient with a chest tube, the best method to properly maintain the chest tube would be to strip the chest tube every hour to maintain drainage, place the device below the patient's chest, double clamp the tube except during assessment, remove the tube from the drainage device to check for proper suctioning. The answer is B. Place the device below the patient's chest. Teaching strategies that would be used would be to establish rapport with the patient and the family, maintaining eye contact during the educational session. Use words the patient will understand. Set goals in partnership with the patient. With each significant bit of information, ask the patient to repeat back the information that you have just provided. Give an overview of chronic obstructive pulmonary disease and pneumonia. including signs and symptoms of exacerbation, medication, and follow-up appointments. Provide a written copy of the material and allow time for questions. Evaluation strategies would be to ask the patient to verbalize what they have learned. Ask the patient to describe in their own terms what community-acquired pneumonia and COP disease are, as well as list the signs and symptoms of exacerbation. Ask the patient and the family if they have any questions or need any additional information. What are some other measures that John could use to verify the patient's improvement? It is important to determine the patient's perceptions of their care. If the nursing measures used are unsuccessful in improving oxygenation, the care plan needs to be modified and reevaluated. Continuous evaluation helps to determine whether new or revised therapies are necessary and whether new nursing diagnoses need to be developed and require a new plan of care. Measuring improvement in terms of activities of daily living and interviewing family members are other steps that John could take. When you would write documentation, what would you do if you were John? Suggestions may include the patient discharged to home, able to state the purpose of breathing exercises and each medication, able to list causes and symptoms of respiratory tract infection, has an appointment in 1 week with a community-based rehabilitation program, scheduled to see the healthcare provider in 2 weeks. Prescriptions are explained and provided to the patient, accompanied the patient to the exit, left with wife and son. Knowing the baseline range of vital signs. Only suction 2 times with the procedure. Perform tracheal suction before pharyngeal suctioning. Use caution in suctioning patients that have a head injury. Do not use normal saline instillation into an airway before suctioning. Understand the institutional policies and procedures before stripping or milking any chest tubes. The most serious tracheostomy complication is airway obstruction. COPD patients that are breathing spontaneously should cautiously receive high volumes of oxygen.